Okay, focused physical exam. You still want to know the past medical histories, medications, allergies, all that deal, but it can be focused versus a complete. Okay, when you're doing like coma removal, you still want to ask all of those things of anesthesia, risk, bleeding risks, but we're not intubating them, right? Within our clinic, it's a ambulatory procedure. They come in, we do it, and then we leave. Okay. Informed consent is still really, really important. You should never do anything, poke anybody, or cut anybody unless you have a informed consent. Right? And written informed consent. Written in lay terms that the person or the patient understands. Also listing all the alternatives. We need to take that lipoma out. What would happen if it doesn't? If we just leave it? Right? We need to do that toenail removal or the partial toenail removal. What would happen if we don't? Right? Worsening infection, potential osteomyelitis, right? So like putting in those alternatives to have that patient really understand risk, benefits, and alternatives so that they can make a informed decision. Okay? Again, you, patient, and a witness has to sign. And then you do a timeout prior to any injection of anesthetic. Okay, so before anybody gets poked, we do a timeout. And what does a timeout include? Right person, right patient, or right procedure. You have the right supplies, right medication, all of the 5 or 6 R's, right? All right, so positioning your patient, okay, making sure that they're both you and the patient are comfortable. Don't be needy and constantly cater to the patient and now you have a bad back. Okay? Lift the table up so that you are working here and not hunched over. Okay? If the bed can't lift up, maybe sit on a stool so that you are comfortable. If this is going to be a longer procedure and not just a simple, skin tag removal, you don't want to become uncomfortable as a provider, right? Because then you're going to be sloppy, you may make mistakes because you're then thinking about your back pain or your spasming versus what's actually happening with the patient. Okay? You don't want to get distracted. You want to try to plan your incision and closure. What that means is trying to find those natural skin lines so that you're cutting along and limiting the amount of tension that skin closure may have. Okay, so natural skin lines, they kind of run different in every part of the body. It just really depends on where you're going. The only thing that's the exception is when we're doing a flexor service of a joint, we want to do transversely. It's just the way it is. Ortho doesn't necessarily do this because they will cut up and down at the knee. Okay. Or they will cut up and down on the knee versus they don't go in the skin lines when it's over a flexor surface. Okay. So say you did a horizontal line through that skin surface and you were trying to get less tension, but unfortunately as soon as they bend their knee, tension and it's going to pop. So if you have a longitudinal one or a horizontal one or a perpendicular one to the natural skin lines, when you bend it's going to pull at the ends versus pull at the middle. Okay. When you're doing an ellipse, we try to make sure that it's 4 times longer than the width. Okay, just one of those videos showed you how to measure how to do an ellipse, because you don't want to cause dog ears on the ends. Okay, if it doesn't actually, the middle doesn't come together, and it's too fat versus short, and you're gonna have weird little things on the ends that you can't really incorporate into the incision that you just made. All right, prepping. You can use betadine, you can use chlorhexidine. Okay, you do it in a circular motion, 3 times starting from the center, working your way out, go away, do another one, working your way out. Okay, you do that 3 times to get it clean. It does not matter which one you use, you just have to make sure that if you're using chlorhexidine and you're using or planning to use some sort of cautery, that you wait the desired, I believe, 3 minutes so that it lowers your fire risk. If you miss an area, don't go back. Just get it in your next time you go around. Okay? Because every time you go further out in that circle, you're picking up debris or dirt and germs. So if you have already cleaned that center and you take that swab and go back to the middle and do something, you're just now transmitting all of those germs from the outside back to the middle. You just basically didn't do that one. Okay? Draping the area. Okay, you should have sterile blue towels in your clinic. And when you get them, okay, you're gonna, when you're gowned and sterile gloves, okay, you, depending on where it is, you can do the, fold at the top and kind of, kind of putting around the area in which you're doing it, or you can kind of do, if I can do it, it's harder to do it with a piece of paper than, so, you kind of do something like this, and so then you have 4 of them, and your circle would be here. Okay? So, again, easier with a blue towel than a piece of paper. But there's ways to make sure that you have a nice sterile field around wherever you're doing. And then you can put other towels or other drapes, sterile drapes around that in case you need more room. You want to make sure, because like all your utensils and all your tools that you're using should be kept on a blue thing, right? It's all sterile, it's all clean. You don't want to put it on the bed, you don't want to put it on a nail cart with no blue, right? So blue means sterile, blue means clean, right? So once you're gowned, then if you have that nice decent area, then you have area to work and put your tools instead of constantly going back and forth. Okay? Choosing the right anesthesia. 1-to-1 ratio of lidocaine and marcaine are pretty good. You can just use lidocaine. You can just use marcaine. You can just use bupivacaine. It doesn't really matter. It just depends on what you have and how long you want it to work. Okay? Is it in an area that you know is going to be pretty well vascularized? Maybe you want epi. Okay? It just depends on where you're doing it and for how long you need that area to be anesthetized. Lidocaine starts faster, but marcaine lasts longer. And again, so if you're using that 27 gauge, 1.5 or 2 inches, I think it's 1.5 inch, you can bend it a little bit so that you can actually get right up underneath the skin. Once you do it, you'll understand. You don't want to bend the needle too much to the point of the breaking, but you can bend it just a little bit so that you have a better angle into the skin versus if it's a straight needle trying to get your syringe down flush with the skin in order to do that sub-Q. Sometimes it's harder. So if your needle's already bent, then you have a little bit more room to get into that sub-Q point. Always insert the needle fully. Aspirate. Make sure you're not in the vessel. And then as you remove the needle, that's when you're pushing in the fluid. Or in the anesthetic. And then if you don't want to necessarily fully withdraw, you can redirect underneath the skin in the subacute area. You just have to be careful. Follow your planned incision. Don't go rogue. Okay, once you have that lidocaine or whatever you're using underneath, it's going to bubble up the skin. It's going to cause a little bit of edema because there's now fluid in that subacute region. So if you have a planned incision line, that's your planned incision line. Don't go rogue and think, well, now it's swollen, now I want to go here. Like, that's where you anesthetize. So cut where you planned on doing it before you instilled all of that fluid. Controlling minor bleeding, normally it's good with just direct pressure. If you have electric cautery, great. Most clinics don't. At least none of my Navy clinics have had electric cautery. If you need to, we'll practice figure eights and whip stitches when we do the suture lab. That's a pretty quick way of closing things in for ligating a little vessel that's continuously bleeding. Any specimen, anything that you take off the body should be sent to pathology. Okay, so making sure that those those path containers with formalin or some whatever the fluid is in there, it's labeled correctly with the patient, the name, the birth date, the DOD, however your lab wants to do it. Sometimes you can actually, I think now with Genesis, just print off the label and stick it right on there. If you do more than one, it's most likely going to be under the same, if you're cutting off more than one lesion, now if it's the same lesion in different pieces, that's fine, that goes in one. Okay, but if it's different lesions, you're going to want 3 or however many different containers, and you can put it underneath the same order, but it's like container A, container B, container C, that kind of thing. Okay. When the wound is open, no matter how big the wound is, I mean, within reason, if it's a tiny little thing, you can use a Raytex. Okay? If you have surgical sponges and you know it's going to be a pretty bleedy kind of like lymphoma removal, then that's something you want to do, but you try not to use any gauze that does not have a radio-opaque line. Okay? If you're doing a decent size lymphoma removal and you're trying to you may have to pack something in there, it better have a radio-opaque line on it because you can then x-ray it and it will show up. Versus if it's just a normal gauze, cotton gauze, it's not going to show up on any x-ray. Okay, so Raytex, Ray, radiographic, and lap sponges are the ones. We'll see those in a little bit. Alright, this is just a generic procedure go by, okay? I'm not going to test you on this slide, but this is just, kind of some of the things you need to start thinking about when you are getting ready to do these procedures. You have everything that you need to have in order to do that procedure and not have to go in and out of the room multiple times. Procedure notes, extremely important. Anytime you cut, poke, do anything to a patient, you must have a procedure note. Okay? You need to have the patient identifiers. Who did you cut? Who did you do whatever to? Whatever time and date. The time is important. Because say you do a procedure note, you do something at 2 o'clock in the afternoon and they show up at 5, the ER, or they show up to the ER at 5 because they're bleeding, then they know, okay, it's only been a couple hours versus, was this an 8 a.m. procedure, right? Or how long has it been since that procedure? The diagnosis, this does not have to be the actual path diagnosis, lymphoma. This is a skin nevi removal. This is a whatever you think it is that you're trying to get off or take out of them. Okay. So this is kind of what you call a pre-op diagnosis. So it's not necessarily what the actual diagnosis is. You think it's a lymphoma, but really it's a sarcoma or something, right? Hopefully not, but it's just what you think it is. This is why you're taking it out. Your actual procedure, step by step. This is not just I took out the lymphoma. This is discuss the patient with the patient, risk benefits. We have the signed consent form. We started the procedure under sterile conditions. We used beta 9x3. We draped and prepped in a sterile fashion. We instilled this many cc's of 1% with epi. This is what I did a 2-inch incision, removed the lymphoma completely, send it to path, close the subdermal with 3-0 Vicryl, close the skin with 4-0 monocryl with a running subcutaneous suture. Dermabond was placed over the top. Patient was then, pre and post-op pain. Pre-op pain was whatever, post-op pain was 0. They're still anesthetized. There was no complications during the case. And the patient was discharged home with ER precautions. It is very, step by step. Someone should be able to read your procedure note and know exactly step by step what you did. It is tedious and it is annoying, but unfortunately, once you do a few of them, you can make a right? Make a Word template. When I was in primary care, I think I ended up with like, it was like a 30-page document of all my templates. I was like, I talked to somebody about hypertension today. This is what we talked about, right? And then I would copy and paste it into my note, change a few things, and then I'd be done. Okay, you don't have to do it over, you don't have to reinvent the wheel every single time, but you have to make sure then that you either underline or highlight the stuff that you need to change so that you don't have a generic thing actually to the patient. You update it, but you can start with a template. And I think Genesis has dot phrases now, which make it even easier. Okay. Did a surgeon help you? Did you have an assistant? Did one of your corpsmen or one of your medics come in and help you? Those are really important. They need to be in the know. Okay. What anesthesia you used? Describing the procedure, blood loss. Oh, estimated blood loss is really important, right? If you say 5 milliliters and it was really 100, right? Probably not great. Ortho is when you get to surgery and like in your ER and your other rotations. Ortho is notorious for doing low. Oh yeah, I only lost 5, but they did a complete hip reconstruction. Like there's no way that you did a complete hip reconstruction and only lost 5 mils of blood. There's no way. So like they're ones who consistently go low. Did you put any drains? Did you leave anything? Okay, any complications? How did the patient tolerate it, the position, and then sign it? Clean up after yourself, okay? The red biohazard containers, we really should use these correctly. It is extremely expensive if you're putting stuff in those red bags and it doesn't necessarily need to be. Okay, these are burned by weight. So if you are having your entire procedure go in the red bin, that's very heavy. Okay, you don't need to do that. Anything that's saturated with blood can go in the biohazard. Okay, sharps go in the sharp container. But everything else, if it just has a little bit of blood on it, all your gown, your gloves, everything else can just go in the trash. Okay. All right, discharge paperwork, wound care instructions must include, we'll talk about this in our next lecture. But basically, how do you want the patient to like take care of the wound, right? You have to give them that in your discharge instruction. Biggest thing for minimizing scars, avoiding sunburns up to 12 months. Okay, so using sun protective clothing or sunscreen. We really do not recommend any type of derma or scar minimizing creams for up to 6 months. How long can they not take a bath for? Right? And submerging in water. You have to sometimes, unfortunately, includes hot tubs, oceans, rivers, not just a bathtub. Okay? People will sometimes not understand that, and I've learned the hard way, so I make sure they understand submerging means any submersion in any body of water, whether it's a bath or the ocean. Signs and symptoms of infection. We see this a lot, right? But what does it mean? Does that layperson actually know what signs and symptoms of an infection actually look like? Is it red? Is it warm? Is there pus coming from it? Does it smell horrible? Right? Is the wound starting to break down? So you can say that in your note, but I would caution you to make sure that you're actually telling the patient correctly as to like, hey, this is what this means. Okay? Because the next day they may wake up and be like, oh, it's more painful and it's red. It's just the normal inflammatory process because the lidocaine wore off. Versus, oh no, you have fevers, you have red lines going up your arm, it is red, it is purulent, it is fluctuant, like it's different. So make sure they know the difference. When do you want them to follow up? Is it a 2-week? Is it, we're packing this, so I'm going to want to see you tomorrow to make sure that what we're packing is actually what I want to do and continue. And then work and school excuse, especially those working in primary care. Kiddos, can they go be in gym? Can they participate in gym? And they may not, right? If their PE right now is swim, they're probably not going to be able to do that. If it's a contact sport and we just took off something on their face, we probably shouldn't have anything that like dodgeballs can go towards their face. For active duty, knowing what their occupation is. If they are a desk jockey, probably can go back to work, depending, right? But if they're a mechanic and they're around grease and gross and like fuel and sand and, you know, it's just a dirty environment, we may want them to be off work for a minute. All right, don't do this. This is a bad repair. They came to me in at Lejeune. Okay, so the edge didn't actually heal correctly, and so it marsupialed. And so we sent him to plastics. I'm not sure how this ended, but you can imagine that that's not going to be great for like haircuts, right? Very painful. It can be causing infection. So when you do repairs, make sure you're doing them appropriately. Wound dehiscence. Okay, so when you have too much tension on that wound, but you didn't necessarily close it correctly, this is what can happen. This is what wound dehiscence looks like when you have skin bridges, right? Like that skin bridge looks like it is on its, you know, it's pretty taut. Okay? So, this is just something that you have to be aware of that can happen. What do you think the treatment for this is? Nope.
Plastic surgery.
Nope.
Open wound care. There we go.
It has to heal by secondary tension, right? So we had to individually pack every single wound, and they had to take months to heal. So this is why we try not to put stuff under tension, okay? Now, this will heal, right? It's already starting to heal. But you just have to be careful, because this guy, I think, came to our clinic probably every 3 days, or at least, I think we had enough every week, just to make sure that his wounds were continuously getting smaller. Okay. So this first picture, is what the guy ended up leaving the ER with. He was admitted, and I showed up the next morning and did his tertiary exam, which we'll go over in trauma. And I saw this, and I was like, doesn't look great. Probably not going to heal right. Okay, you can see that there are some staples that are barely hanging on. Okay, what you don't see is underneath there is a huge hematoma. Okay, because we didn't do any deep thermals, right? His initial trauma, you will see this, the initial trauma survey that we do is staunch the bleeding. So staple, 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 do the rest head to toe, okay, because we want this massive hemorrhage comes first. So we do something to cause that bleeding to stop, but you still have to go back after the primary and secondary surveys, after the life-threatening injuries have been assessed, and fix that, okay? So I ended up giving in some fentanyl, numbing up, like cutting or taking out those staples, cleaning everything out. I think I used 2 layers of deep thermal, so inside and then basically closing down that flap so that it wouldn't cause a seroma or hematoma underneath again, and then re-stapled it on top. Okay. So, not a bad thing to start with this, but don't send them upstairs from the ED looking like, or home like this, because it will never heal. Okay. All right, follow-up appointments, just some important points. Make sure that when you're walking into the room, you have their PAC report. Have it printed out so you can actually show them exactly what it says. Ask them how they're doing, empathy. Okay, is their pain meds actually working? Have they had any complications? Right, we told them to pack and repack their wounds twice a day with a shower in between. Are they able to do that? Have they been able to do that? Right? There have been many times where I've had people show up and they're like, oh, I don't remember you saying that to me, so I haven't changed it out, and it's been a week. Okay, so, yeah, reviewing the PAT report with them, you actually have to examine that surgical site. Okay, if there's sutures, depending on how long it's been, okay, you may leave them in, you may take them out. If it's been close to that 2-week mark and the wound still doesn't look great, I would still take out the staples and the sutures. Okay, the skin at some point is going to start growing over them, and it will be extremely painful for them to take them out. So if you take out the staples and the sutures and it still gates just a little bit, that's when steri strips come into play. Okay. Because at that point it's been 2 weeks, it hasn't grown any bugs, it isn't showing any signs of infection. So at that point you can reinforce that wound for another 2 weeks with steri strips. As long as it's not like on the head or something where the steri strips aren't gonna stick. Okay. Just any concerns, make any referrals, taking out sutures. Make sure you clean the area, loosen up any dried blood or scabs around them. Sometimes it's easier said than done. You can either use suture removal scissors or an 11 blade. You want to try to pick up the knot, whether it's with one of the tails, okay, and then cut. Also, it's really important to know and read back before you take these out what actually was done, like how was this closed? Was it a running suture? Was it an interrupted? Was it a horizontal? Whatever you did to close it. There have been a few that are really bad mangled injuries, and I look back and I'm like, I don't really know if this was done with a running or not, so a lot more investigation had to happen, and my eval of that person to be like, am I just taking out one, like individual, or am I trying to find this entire length of a running stitch? Okay, you don't want to leave any foreign bodies behind, so we try to take out all of it. Okay. Staples, even better. Okay, you can use hemostats, but they do make staple removers. Make sure that there's 2 prongs on the bottom and 1 prong on top. If you flip it upside down and you have the 2 prongs on the top and 1 prong on the bottom, it's actually going to close it more into the skin. Okay, so if it's 2 prongs on the bottom and 1 on the top, it actually then kind of causes it to like make a W and go out of the skin. Okay, or make it down. Sorry. Okay. All right. You went through all this. These are stuff that you can see, that you will be able to do and be credentialed to do. Okay? Epidermal inclusion cysts, sebaceous cysts, pilar cysts. Basically, pilar cysts are like, it could be a sebaceous cyst or an epidermal, but on the scalp. Okay? They're normally very vascular, as the scalp bleeds a lot. So just be aware of that. Epidermal, they're going to be hard. That's more of a lipoma. That's more than epidermal. You'll have like a pore for epidermal. It'll be like a hair follicle. Okay, it'll be very stinky. But sebaceous cysts are stinky and wet. That's great. You guys are PAs. This is what you signed up to do. All right. Any questions on minor procedures? Let's then go to post-op complications. That last slide of the minor procedures were all of the sutures. We will see all those videos on the suture day. So again, watch them on your own so you can kind of get an idea of what we'll be doing. Or we'll do all those. All right, post-op complications. Okay, those are all of your objectives. You can find those in the syllabus. Okay, processes, like why do we want to know about and study post-op complications? Quality assurance for, process improvements. Okay, if we can do it better, easier, the better it will be for the patient. So we do review these. We will do quality assurance and annual credentialing. That may change with the universal credentialing, but given how screwed up the universal credentialing is, we will see. Communication, proper handoff, timeout, consents, all that did you actually do it? Did you do it how we were supposed to do it versus, oh, I took out that, like colon, I didn't write a note, there's no, informed consent. And if something were to happen, have a post-op complication or a post-procedure complication, and some of these things aren't there, you're gonna have to answer for it. Okay. Documentation of care, again, is standard, right? This is why we all do a big old PAs program so that you guys are all learning the same information at the same time. We want to standardize it. Reporting complications, morbidity, and mortality. So these are M&M conferences. I highly suggest you go. If they have them at your hospital, they do have them. Sometimes they're closed door, meaning that students aren't necessarily allowed unless you're on that rotation. Okay. Basically, these are patients who had either death as an outcome or a severe, like, morbid complication. Okay, like, we didn't catch the bleeding out and now they're a vegetable, or, we caused a stroke or something, right? Major complications go to morbidity and mortality conferences. And then there is those lovely ICE comments. Patient feedback, okay? They're there for a reason. Try not to get, like, anxious or, like, if you get a nice complaint. I've gotten one ICE complaint in my career, and it was because I was taking too long. I was brand new PA Yuma, and DHA had just come out with the one issue per appointment rule, and I said, fuck that. I have patients who are on 5 different medications. I can't just change one thing and not look at everything else. Like, that's just not how I work. Which is now why I'm not in primary care. So, I take my time, and I had the same amount of time per patient, but that made my day run long, and someone didn't look at that. So, but patient satisfactions are really important. ICE comments are not just complaints; they can be critiques or congratulations, or hey, you did really well, you listened to me. So just because you get a nice complaint doesn't necessarily mean that it's always negative. All right, common surgical complications. We have bleeding, anesthesia, medication reactions, infections, injury to surrounding structures, poor cosmetic outcomes, between foreign body, recurrence. Any squirmish people in here? Anybody faint at the sign of blood? We got a couple, so we'll see. All right, retained foreign body. This is the biggest one. Okay, we don't want to leave something behind that we did not mean to, which is why we do not use those sponges with no radiopaque lines in them. So lap sponges, those blue, both the blue at the bottom and the blue tag or tail, all are radiopaque, and the Raytex are radiopaque. So those are the only two gauzes that you will see in the OR. Okay, when we're in a body cavity, we cannot afford to have just regular gauze that does not show up on X-ray. Okay, they will be left behind because once you get into a belly, depending on how big that belly is, you will understand that things get lost behind spleens and livers, and you just don't want that to happen. Okay. So post-op complications, timing. Okay, so what do we kind of see between like the acute phase and more of the later stages? So within the first 0 to 48 hours post-op, okay, respiratory and cardiovascular issues are number 1. Okay, you're not going to come out and have pneumonia hour 0 from a surgery. Okay, your wound is not, unless it was already infected. Your wound isn't going to be infected within 2 hours of leaving the OR. Okay, that takes time to really mature. So, failure to maintain ventilation, aspiration, which can lead to pneumonia, sudden cardiac arrest, hypotension. Those are our big ones. Okay, and then what can we see after 2 days? So 2 days to 30 days. Right, we have those localized infections, UTIs, because that Foley may have not been placed either as cleanly as possible, or it's just their hygiene has not been well and they've developed UTI, or they have pneumonia. Then we go into our systematic inflammatory response syndrome, our SIRS, and our multi-organ system failures. okay? Everybody remembers radiology, atelectasis. This is a acute, okay? If you're laying there, it can develop over days, but normally it's pretty early on, okay? They're laid up, they just have major like lung issues, or they have a pelvic fracture or something where they're just old and decrepit and they can't get up and walk. Their lungs aren't aerated like they used to. So decreased gas exchange is a very common complication of general anesthesia. Okay, the amount of tidal volume that we breathe in on a normal basis without a vent is different than what we breathe for them on a vent. Okay, you'll see that. I think it's in this lecture. But basically, you're on a vent, you're breathing a little bit lower tidal volume so that we don't overexpand you, right? But that also leads to the alveoli collapsing. What does it cause? Pain, right? So they can't really cough or take a deep breath. They may have hyperventilation. You're going to have retained secretions because they can't take those deep breaths and those low tidal volumes. Someone who's a smoker, underlying lung disease, your cystic fibrosis, your COPDs, your emphysemas, your chronic pulmonary diseases, those are going to be a risk factor. And then someone who's on prolonged anesthesia. Okay, if we are having to mechanically ventilate you for a long time, your risk of atelectasis goes up. Presentation, you're going to have a low-grade fever. Very hard to distinguish between a post-op fever, which is normal. Okay. If we just did a huge surgery on you, right? If we did an exploratory laparotomy and we cut you from sternum to pelvis, do you think your body's natural inflammatory process is going to be kicked in, right? That also causes a low-grade fever. So trying to figure out whether it's just a post-op normal fever or atelectasis, sometimes it's hard to figure out. But they will have decreased breath sounds. Versus if there's no decreased breath sounds or basal arrhythmias, or we don't see it on x-ray, then it's most likely a post-op fever versus atelectasis. So there are certain things that we can hear and see to try to differentiate between the two. Okay, so how do we prevent it? Post or pre-op, right? Smoking cessation, we try to get them as low on their smoking as we possibly can. If we can get them to stop, great. If not, as low as we can. We want to just maximize the pulmonary function. Okay. Post-operatively, taking deep breaths, coughing, they are not going to like this. If we just cut them open, their belly is going to hurt. They're not going to want to cough. Okay, but they have to. Taking those deep breaths, using that incentive spirometer is going to be their best friend because atelectasis can lead to pneumonia. So if we can get them to ambulate and use that incentive spirometer, right, to take those deep breaths in and actually pop open the alveoli, they're going to be less likely at risk to getting a pneumonia. Pain management, right? We can give belly patients like a PCA, meaning the patient-controlled anesthesia. They have the ability to give themselves a dose every so often. We program it in. Or if it's something like a lot of rib fractures, we can do the rib blocks. Chest physiotherapy and pulmonary toilet. Toilet does not mean a normal toilet. Toilet means basically trying to beat the phlegm out of your lower lungs. A lot of times this is just by wearing a vibratory vest. Okay, do I have any respiratory techs in here? Basically it's like this nice little vest and it has these cups in it and it actually like shakes the patient, so it breaks up that thing. Before, olden days, people would actually smack their back and actually like lay upside down so that that mechanical pulmonary toilet, that mechanical pulmonary physiotherapy would actually break up that mucus and they would cough it up and they would have gravity help. Okay, we don't do that so much anymore. We can do nasotracheal suctioning if they're still ventilated. We can do oral tracheal suctioning as well. And then therapeutic bronchoscopy, that is like our Hail Mary kind of thing, like, you know, maybe they have a mucus plug from this, or, you know, whatever, like that something's just not working, so we'll stick a scope down, bronchoscopy, and actually look, and we can do suctioning, we can do irrigation of the lungs, there's a lot of things we can do with bronchoscopies. Alright, pneumonia, fever, tachycardia, productive cough, rales and diminished breath sounds. Normally you'll have the diminished dependent on where the actual, like what lobe is actually infected. Okay. And I know we didn't do the thoracic chest yet, but, or lecture yet, but pneumonia is fluid in the lung tissues, different from a pulmonary effusion, which is fluid around the tissue. It's outside. Okay. So there's a difference between pulmonary edema, pneumonia, and pulmonary effusions, depending on where they are and what they're doing. So chest x-rays, you may not see it if it's early. May just be a little bit of infiltrate. If it's later shown on x-ray, then it'll be more of a consolidation. Treatment, we give them antibiotics. We address the pulmonary toilet. If they are in mechanical failure or ventilatory failure, we will intubate them. And we are trying to maintain their PCO2 and their O2 stats of 35 to 45 respectively, and greater than 95% O2. Okay? Those are the stats that we are trying to make sure that we don't worsen their pulmonary status. Okay? VAP. So pneumonia would be hospital acquired if their hospital stay is greater than, I think,
48 hours.
how many days?
3 days.
2 to 3,
Longer than 48 hours.
or more than 48 hours, okay? Then you have community acquired, right? They don't, no hospital. And then you have ventilator associated pneumonia. Okay? They have to have been on a vent. They cannot have that unless they've been on a vent. And normally it peaks at day 5, and if they've made it on the vent past day 15, they're probably not going to get it. Okay? VAP is awful. It's like widespread pneumonia. It can still be consolidated, but it, like this guy has it on both sides. Just nasty. So what do we do to help prevent while they're intubated? Elevate at the head of the bed 30 to 45 degrees. We want to do post-pyloric feeding so that they're not having GERD, they're not having that backwash of acids and food up through their esophagus. We do ventilator liberation trials, okay? So this includes 2 things, both a sedation holiday and a breathing trial. Okay, so every morning when you run in the ICU, someone who's on a vent, we're gonna decrease their sedation, and then by the time we go to round, their sedation is light enough that they can actually open their eyes, they can follow commands, and then we basically put their vent on a spontaneous mode, meaning can you breathe on your own through a tube? It's not comfy, the patients hate it, but we have to try those trials, because if not, we're never going to know when they're ready in order to be extubated, right? If they're just constantly intubated and they're constantly sedated into that medical coma, we're never going to really know unless we lighten things and have them try on their own. Plus, when they actually try to take those deep breaths, it helps get that bigger tidal volume than what we're giving them to help prevent atelectasis or worsening atelectasis. Okay. Minimizing the oversedation. So we'll talk about RAS scores, which I don't know if they did yet or not. But basically, RAS scores are like you guys right now are probably a -1 because you're sleeping. Okay. Me, I'm a 0. I'm awake. I'm talking. I'm alert. Okay. -5 is comatose to the point of I'm gonna give you, excuse my language, a purple nurple, and you are not gonna flinch. You are not gonna care. You are so under sedation that you are not going to move. Okay. Now, what we really want is like a -1 to a -2, depending on their injuries. If we have somebody who has a nasty brain injury and we want them in the deepest coma possible to give their brain a rest, we will put them at a -5. And or if we can't get them into a -5, we will actually put them in a barbital coma to get their brain to like shut down, to rest and heal. So, but for normal people, medical and surgical ICUs, we really want to try to have as minimal sedation as we possibly can. And then aggressive oral hygiene. These are orders. Okay? You as providers need to put these orders in for the nurses so that they actually do the oral care. Most of the nurses, even if there's not an order, will just do it. But it is an order that we have to give most of the time in order to say, okay, every 4 hours or every start of every 12-hour shift, I want you to brush their teeth and make sure that their oral hygiene isn't getting gross, right? They're not going to be able to brush their teeth on their own. They're sedated. They're in a coma. So it's up to us in order to do that for them, so that you guys know after 12 hours, your teeth probably are like, gross. Imagine that days on end. Probably not great, right? All right, aspiration pneumonia. We'll do this slide and then take a break. So, common cause vomit. Okay. This is why we normally have them not eat or drink anything for a few hours before, right? Because most of the people will vomit on induction or immersion of anesthesia. Narcotics, right? If someone tells you, hey, if I get morphine, I will puke, take that into consideration, right? If they have an ileus or bowel obstruction, which we'll go over, okay, basically ileus is your bowels are stunned, they don't want to work, their peristalsis is not, like, did I get your sneeze? Bless you. So yeah, their bowels are stunned, they don't want a peristalsis, so it's kind of just like the food just sits there. And with bowel obstruction, one of the normal signs and symptoms is vomiting, okay? We're gonna cover that. Increase abdominal pressure if they're pregnant and or really obese. Sometimes, just having them laying flat on the bed can sometimes increase their abdominal pressure, making it so that they have more GERD. Altered mental status, they're not going to protect their airway. So prevention, we already talked about this, NPO, doing nasogastric tube decompression as soon as they're under. Management, we will, depending on where it is in the case, if we just started, if the anesthesiologist can sometimes do bronchs, if they have time or if they have it in the OR. Otherwise, if we think that it's a lot of like solid material that they've got into their lungs, we will actually do a bronch and wash out as soon as possible. Try to get out as much of the fluid material out. Bronchial hygiene we talked about. So we only give antibiotics if pneumonia develops. Okay, we're not preemptively or proactively giving them preventative antibiotics. Okay, just because someone gets food in their lungs doesn't always necessarily mean that they're going to become or have pneumonia. But if they develop pneumonia, then we will. And sometimes it is so bad that we have to mechanically ventilate because they go into respiratory failure. So not great. Okay. All right. Take a minute break. Wake up. Go get some cold water.
Heat it all up.
Wow, Sylvester.
Yeah.
Go for in class. Get your counselor under control, man. Get your counselor. No problems in class, alright? Get your counseling, man. He was studying instead of nervous.
I'm surprised I didn't get more aroused. You guys are like really that's the chat. Not with it.
We went to see there's a lot of resort. Get 40. Get a video? So you convert the whole thing is you convert to Hilton's Wingstay. It's not the best use of space to do that, but
She's so happy.
I was part of
I didn't feel like that.
yeah, like I haven't seen those ones since like after that I stopped watching.
When he stopped, like when he was not with us, he didn't like the first several months. I was like,
I always check these the day before so I don't have to run around with it.
well, apparently I'm good. I thought she was happy.
Nathan Booty. It's just the notability. Right, this week up. Hey, dude. When you review that, I think the focus is on the boss route.
Alexander was one of the workers.
Yeah. But you can't get any of the.
Yeah.
I think the air kicked off. It was almost like I was down to the screen, but it doesn't.
Stop sharing, very good.
my car, the AC is nice.
About to take off.
There you go.
I did not get to
I think like professionalism is a thing, right?
What are you doing? There's no hosing. It's like, I'm trying to go to some black market. Or value. That'd be another way. Value. I got cheap though.
Ready to get back into it? This is your time. Alright, 15 minutes is all we have left. Navy and Army have already canceled prep today. I'm guessing the other services will follow suit, or if they have already. Alright, so 50 minutes. I need your attention for 50 minutes. Do you think we can do that? Then we can leave, we can all leave this chapter, please. Alright, pulmonary edema. Okay, so this is fluid that is built up in the lung parenchyma. This is in the tissues. Okay, but it's not necessarily infective like pneumonia. Okay, this is just fluid versus bacteria and pus and all that yucky stuff. Okay, so we get this with fluid overloaded. Okay, when our hearts can't keep up, we have that CHF, we have acute exacerbation. So fluid overloaded, we have renal failure can cause this as well. Okay. You can have flash pulmonary edema, which I've had, and ended up actually losing the patient. Okay, so this can be a big deal, so we need to watch out for it. Management, we really have to be judicial with that fluid. Okay, sitting them up, potentially giving them diuretics. You will have like tachycardia, you may have shortness of breath, you may have chest pain, you may have like pleuritic kind of chest pain. The symptoms are kind of widely spread out, but you do still have to consider a pulmonary embolism, an MI, and rule it out. Okay? We have a very low threshold to intubate and put them on mechanical ventilation, depending on how bad their edema is. All right, ARDS. Who's heard of ARDS? All of you should have with Paul? Acute respiratory distress syndrome. This is a non-cardiogenic pulmonary edema, so not from heart failure, not from fluid overload. Okay, this is an inflammatory, not infectious, but inflammatory process. Really resembles pulmonary edema. It's just a different pathophysiology to get there. Okay, it does not and will not respond to diuretics because it's not a fluid overload problem. It's an inflammatory problem. Okay? So you have basically your alveoli filled with fluid. You have atelectasis, which leads to poor gas exchange. And basically how we treat this is that we ventilate them with an increased PEEP. Okay? PEEP is positive end expiratory pressure, which we'll see on the next slide. Basically what this does is our normal PEEP that we like on vents is like a 5, level 5, right? With this, we'll probably go up to an 8 or a 10. Basically what that means is that we're putting enough pressure into their ventilatory system through the vent that even when they're like exhaling, there's still some positive pressure in their alveoli to keep it open. Okay, so an increased end pressure. Okay. So, you guys remember this graph? It's a lovely graph, right? It's phenomenal. Okay, so these are our normal, this purple line, right, is our normal breathing. Okay, you have basically these first two are normal breaths. Those are your tidal volume, in and out. Okay, when you take a deep breath, that's how many liters you actually go up to, right? For me, my liter capacity is probably 4.5, maybe 5, versus someone who's taller is maybe 6. Okay. Then you have, if you exhale everything that you possibly can, do you think you're going to get all of your air out? No, right? You have a residual volume, right? That's your deep space, or your dead space, okay? When we're doing PEEP, that's what we're trying to keep open. So when you're just breathing normal, that's your tidal volume. You have, when you take your deep breath, whatever's above that is your inspiratory reserve. Okay, when you take it as long as the exhale as you can, that's your expiratory reserve. But all in all, okay, from that whatever dead space air that you have, all the way up to however much you can breathe in, that is your total lung capacity. You need to take into account all of these different variables when we are setting vent settings. So, these are values that equal respiratory failure. Okay? If they're breathing more than 25 breaths per minute, we have very low tidal volume, so less they're not pulling in more than 4 milliliters per kilogram, so they're shallow breathing. They're PCO2, so they're partial arterial carbon dioxide is above 45, meaning they're keeping hold of their CO2. Their PaO2, so their partial arterial oxygen, right, is below 60. They're hypoxic. They're using accessory muscles. You'll actually see this, we see it a lot in kids more, but like your intercostal muscles, they may be belly breathing, they may be paradoxical breathing. So like when they exhale, their belly goes out, and when they inhale, their belly goes in, but their chest goes out. Okay, paradoxical breathing. They may be using their scaling muscles to try to really bring up and try to, increase their lung cavity capacity. Those are accessory muscles. Okay, so when we're doing routine ventilatory type settings, these are routine. Okay, so someone who is not an ARDS, these are the normal settings that we would put somebody on. Okay, the most normal mode is ACDC, assist control, volume control. Meaning every breath is volume controlled. We give them what we want them to breathe. But we assist them, meaning the patient can initiate the breath, but if they don't, we will give it to them. And if they start taking a breath, they'll initiate that breath and the volume will still get pushed into them. So even if they take a very shallow breath, we're still going to help them with ACDC. Okay? But if they don't initiate the breath at all, every 12 minutes or however your respiratory rate that you set, every time if they have not at that time initiated that breath, they're gonna be given a breath. Tidal volume, we normally want 6 to 8 milliliters per kg. This is based on their ideal body weight. Okay? Just because somebody is 300 pounds obese, right, with a BMI of 40, doesn't mean that their little rib cage has grown. Okay, so we want ideal body weight versus their actual body weight. Respirations, normally between 12 and 16. Peak, normally we want 5. Okay, but we can go up to 10 depending on where we're at. CO2 of water, or CM of water. Okay, FiO2, we are going to start at 100% FiO2. Okay, we are making sure that the amount of oxygen per breath is 100%. Okay. But we will titrate it down pretty quickly in order to keep their saturation above 92. But we will most likely, it kind of goes down in, like, we'll start at 100 and then maybe the next day we'll go down to 80% and then maybe 60. We won't go any lower than 40% FiO2 as long as your oxygen saturation stays above 92%. Okay? Inspiratory to expiratory ratio 1 to 3, meaning your in to out is 3 times shorter. So you're breathing in shorter and then having 3 seconds to breathe out. Okay, that's normal. We can change this ratio depending on what we want our lungs to do. So for ARDS, okay, we might actually set the peak to 15. Okay, 15 is really high. We might actually start with 10 or even 8, depending on how bad their ARDS is, but we can go up to 15. I don't think I've ever seen it above 15. The bariotrauma rate exceedingly gets higher, the higher peak you get. But we're getting very low tidal volumes. Okay, 4 to 6 milliliters per kg per ideal body weight. Okay, so lower tidal volumes, higher peak. We're going to try to maintain the FiO2 less than 60 to avoid O2 toxicity. But again, we're still going to start at 100 and titrate down to 60 instead of 40. We can increase their expiratory time, so 1 to 4. We're actually holding the breath in for a little bit longer, then we release. Sometimes we can put them prone, meaning their back is up, their belly's to the bed. It just changes the dynamics and the mechanics of our normal body functioning to sometimes like give the front or the anterior parts of our lungs a break and kind of hopefully get our posterior lungs to work a little bit better. Airway pressure release ventilation, this is called APRV. This is a type of mode of ventilation that we use with ARDS. It is not one that we use with any other breathing disorders. Okay. Occasionally we'll use it with inhalation, like really bad, it like burns to the airways. But most of the time this is what we use for ARDS. If we get ACDC and PCDC, meaning pressure control, doesn't necessarily work. So what this is just shorter bursts of breath with low amplitude, but a very rapid, frequent. So almost like a ventral, like it's a vibration. It's weird. If you see somebody on APRV, they kind of look like they're shaking a little bit. You won't see this very often unless you're in a medical ICU with ARDS patients. Okay, central lines, we already talked about this a little bit. Obviously into larger vessels because we want the caustic substances to be in a larger vessel versus a smaller vessel. We already talked about long-term placements. Most common complication of a central line is the pneumothorax, especially with what 2 placements? Subclavicular and intrajugular. Good. But we also can have arterial injury, okay, going through the vein into the artery, making a atrioventricular or atriovenous fistula. You can actually just, cannulate the artery, which the femoral, not horrible. I mean, we can definitely deal with that, but putting a cordis into a carotid, not the greatest. We can have continuous bleeding due to aneurysms. We can cause strokes. We can cause cardiac tamponade. We can cause infections. So normally we try to leave them in less than 7 days, or exchange them. Make sure that they're keeping them clean. Yeah. Underlying fat embolisms. We normally see these with long bone fractures. Okay, we're not going to see it with anything else. Long bone. We have to get the fat globules from the marrow. Somehow it migrates into the capillaries and then up into the pulmonary system. Normally we'll see this between 12 and 72 hours after that injury, after that fracture. You'll have respiratory insufficiency. It's basically a pulmonary embolism, but with fat. Okay? So you'll have the same type of symptoms of a PE, but it's a fat embolism. It's treated differently. With a PE that's being caused by a thrombus or a blood clot, we can give clot-busting drugs, right? There is no clot-busting drugs for fat, unfortunately. Okay. Supportive care, normally we just use additional and positive pressure, so increased peak. Diuretic sometimes helps. Sometimes we do have to go in and mechanically remove it. Early fixation of those fractures are key. Deep vein thrombosis, we have the Birchhouse triad, so we have venous stasis. What is venous stasis? Stagnant, right? So they're not pumping, they're not, basically blood's pooling and it's not circulating like it's supposed to. Endothelial injury. What's that?
Inside the blood vessel.
Wow, a lot of members. So basically any injury to the inside of any vessel. Okay, the inside layer of any vessel is the endothelial lining. So any injury to that lining, you can cause a clot to form. Okay? And then hypercoagulability, if your body's already at a heightened sense of making clots, you're going to be at a higher risk of getting DVTs. Major risk factors, so major traumas, malignancies, age over 40, pregnant, postpartum, using OCPs, so birth control, okay? Any history of DVTs, you're at an increased risk of getting another one. Prolonged immobility, so our long travel by air, bus, trains, right? This is why you should get up and walk on long plane rides or do your foot pumps. Sitting here in this class for 8 hours a day is prolonged immobility, so get up and walk. Don't be one to cause a DVT. Which one is the wrong one? Which one's the one with the DVT?
They're right.
The right side, right?
All left,
Red
they're
one.
right.
Versus the pale one. Alright? What if it's the pale one? What diagnosis would that be? No flow, right? So that's your critical limb ischemia. This person doesn't have a tan, okay? So this is a really good example of this might be the normal skin and this is actually critical limb ischemia, but in this case it's the DVT. The red leg, wide swollen leg is the bad one, okay? All right, you can have the Holman sign. What's the Holman sign?
Passively stretch the calf, it hurts.
So you have them lay on their belly, and you dorsiflex their foot, and if their calf hurts, or if you just squeeze their calf when they're just low, with no, if they're passive, you squeeze their calf if it hurts. Being out of proportion is probably, yeah. Their leg is going to be, or whatever extremity, it's swollen and warm. You may have pitting edema. We already went through all those. So DVT, how do you work it up? HMP, like always. Okay, imaging, we can do a duplex ultrasound, we can do a venogram. These other images here are the venograms. Okay, it's basically like an angiogram but with the veins. We want to do elastic stockings, so those nice, very tight compression stockings from their feet all the way up to their hips. Early ambulation, the squeezy devices. Okay, anticoagulation is key if they can have it. While they're inpatient, they're most likely going to be on low molecular weight heparin like Lovenox or enoparinox, or they'll be on heparin depending on if their kidneys can't handle Lovenox. Okay. Or say we just repaired some vasculature and we need them to potentially not bleed, or we need to reverse it very quickly. Maybe we'll put them on a heparin drip. Okay, or sub-Q heparin that, we have to do sub-Q heparin every 8 hours versus Lovenox is once a day. So we could potentially reverse that quicker with heparin. If they still have it when they leave, which they will, we'll put them on a anti-10A or a direct thrombin inhibitor, okay, enoxaparin or endoxidan. You have a lot of new ones right now. What's some of the current ones?
Vaccinated.
It's too hot. Warfarin is a big one, but they have to go to a warfarin clinic. Okay, we actually have to really monitor warfarin, which is why the anti-10As and the DOACs are actually really better, because we really don't then have to worry about their INR. We just have to worry about reversal if they fall into their head. Okay, pulmonary embolism presentations. So how are they going to actually present? So multiple emboli, so like a shower of emboli is actually more common than a one branch emboli, or what we call a saddle embolus. This is one that basically spans the difference or the distance of your left and right pulmonary arteries. Okay, that's a saddle. It goes through both lungs. Most of the time they're smaller and they shower through one lung, one lobe. But a saddle takes out both lungs. Okay, that is like your widowmaker, if you say, for your pulmonary embolisms. Okay, we can treat saddle emboli with mechanical extraction and embolectomy, but sometimes they don't make it to us in time. Okay, so acute symptoms will be immediate. If it's subacute, they may have some increased work of breathing. They may have some chest pain. Symptoms really, they occur over days or weeks, and if it's chronic, they may develop some pulmonary hypertension over years. Some risk factors, same thing for any DVT, same thing for emboli in your lung. Okay. Presentation, they're going to be hypoxic, they're going to be tachypnic, they're going to have possibly signs of a DVT. Okay, so they had a DVT, a little piece broke off and went to their lung. That's the most common thing. So if you have somebody with pulmonary embolism, you better be doing a duplex of both legs to make sure that you're not missing a DVT. Okay? Their presentation may be cardiopulmonary arrest. They may come in dead, unfortunately. Okay? There's multitude of tests that we can use in order to figure out the severity, or if we have a suspicion, like which one is going to be or where it's at. Wells criteria is the one we use most commonly for PEs. Out of these three, that's the one I want you to know. Okay, just know that there's the PERC and the Pepsi scores criteria out there as well, but Wells is the most well known. Okay. So if you have any symptoms of a DVT, you use score 3. Any other, you have a diagnosis that doesn't explain it. Tachycardia over 100, immobilized greater than 3 days, or you had surgery in the past month. Prior DVT or PE, hemoptysis, what's that? Dropping out blood, and then malignancy, right? So if you have greater than 6, score greater than 6, you have a very high likelihood of you have PE. Right? Versus if you have less than 4, maybe get a D-dimer. Okay? I have a soapbox for D-dimers, so we'll get to that. So, When you're doing your HMP, you really want to look for any history of blood dyscrasias. You want to look for cancer and mobility. This may be how you diagnose cancer in somebody. They show up with PE or DVT. They didn't know they had cancer. This may be their first diagnosis. They may have dyspnea, chest pain, hemoptysis, vital signs. Okay, if their pulse ox is less than 95, they're most likely at a worse prognosis. If their initial O2 sat is less than 95, their prognosis is worse. They might be hypoxic or hypocarbic. Sorry. All right, plasma D-dimer elevated. So, for D-dimer, my little soapbox is you should not be ordering a D-dimer if you already, one, have a diagnosis of a DVT, or you do not think it's a DVT. It is backwards, okay? If you get a D-dimer and it's positive, there's a shit more ton of things you have to do in order to like rule stuff out, versus if you don't think it's a DVT and you just want to check the box, you get a D-dimer and it's negative, wonderful. Okay, but if it's positive, you have to do a whole bunch of other workup. Okay, so that's my little soapbox. It's when you think you don't have one, you use that to solidify your rule out of a DVT. Okay, if you already suspect it or you already have a diagnosis, there's no need for it. Okay. Cardiac enzymes, BNP to rule out your CHFs and your heart disease or your MIs. Okay. Anytime you have pulmonary embolism, right? If you have dysphagia, chest pain, hemoptysis, always you have to rule out an MI. Okay. EKGs, you'll see the S1, Q3, T3 about 30% of the time. So it's cool to find it, but it's not necessarily going to like change your diagnosis or your presumptive diagnosis if it's not there. 70% of the time, you will have some sort of non-specific EKG finding. So you should still be getting an EKG, okay? But you may have new onset AFib or right bundle branch block versus if you have S1, Q3, T3, you automatically have, well, you most likely have a PE, but 30%, like 70% of the time, it's not going to be present. You'll have just something else abnormal on their EKG. Have to get a chest X-ray, but it's limited. Okay, you have to rule out other things, so you still get that chest X-ray. The test of choice, though, is that spiral CT with a PE protocol. Okay, so this is a CT of the chest. It'll be with contrast. And the PE protocol delays timing so that it goes through the veins and then through the arteries. So you'll kind of get both. Okay. And then if they have poor renal function, they can't get contrast, okay, or they're pregnant, we do what's called a VQ scan, ventilation perfusion test, thank you. Okay, this is a nuclear study. Okay. That's what these guys are over here. Okay. And then pulmonary angiograms are great if you have IR. They're both diagnostic and therapeutic because they're already in the vessel, they're already in the arteries. If they find one and it's big enough, they can go in and take it out. They can do mechanical embolectomies. Okay, but it is invasive and it does require a central one. All right. How are we going to treat it? Supplemental O2, IV access. Okay, we have to give them heparin. Most likely heparin drip to start with, especially where bleeding is concerned. We can do sub-Q, but we will more than likely do heparin versus Wilrox. When they start to get transitioned out of the hospital, we'll put them on warfarin for 3 to 6 months, or an anti-10A or a NOAC. Okay, a big span, that's one. That's one I remember. All right. Now with warfarin, like I said, you have to have a Coumadin clinic or a lab/pharmacist who's for you, who are really good at doing Coumadin clinic type things. Okay. Okay, if you do not have that access, probably don't do warfarin. You have to check their INR. You may have different doses per day, depending on what their INR does. It's very intensive, which is why they made pivoting clinics. Okay, so doing a DOAC or an NZ10A is sometimes better. Now, for those people who can't take any of that, we have inferior vena cava filters, or IVC filters. These guys are put in there via it's fun. Interventional radiologist, so IR. Okay, it goes up through the femoral artery, goes into your aorta, and basically it's a little bird cage type deal that any DVT emboli that comes off and starts to go up through your aorta to your lungs gets caught. Most of the time we do remove those, but there are people who live with them all the time. Okay. All right, cardiac complications. So we have arrhythmias. This is our number one. If anybody comes in with or post-op has arterial fibrillation, we have to rule out an MI and a PE. Make sure you're checking those electrolytes. Okay. If we gave them a crap ton of fluid, or we didn't resuscitate them enough, their potassium may be out, their magnesium may be out of range, and their heart muscle, their contractility is just not normal. Okay, which we can throw them, or say we gave them way too much fluid, now they're fluid overloaded, and now they're in AFib because we stretched that muscle. Hypertension, hypotension, really just depends on their fluid status, their shock. Okay, if it's cardiogenic shock, decreased forward flow from the heart, meaning the heart's just not pumping like it needs to. If it's neurogenic, loss of neurogenic tone, most likely either from a stroke or from a spinal cord injury. Distributive vascular tone, maybe they're anaphylaxis, maybe they're whatever, right? It's just a lot of different things we need to consider when we're thinking of cardiac complications. Gastroenterology type complications, there's a bunch. Ileus is our number one. Most of the time it's caused by any time we touch the intestines, like actually touch them, they don't like it. They get pissed off real quick and they'd be like, nope, I'm not gonna work. I'm gonna be shocked and I'm gonna be stunned, I'm not gonna work. I'm not gonna do what I normally wanna do. So this is a very common thing that we see in most abdominal surgery post-op patients. It can also happen from hypovolemia, right? So if we haven't resuscitated them enough, right, what does our body do to try to compensate? Tries to concentrate that blood product, all of their blood to the major organs, so brain, heart, lungs. Then your gut kind of shuts down, doesn't want to do what it normally wants to do, so we really need to increase their resuscitation. There are some things as the ERAS protocol, okay? So to mitigate ileus, if we know that we're going to do a lot of belly, like touching their intestines or removing some intestines, we can put their NREG is a great drug. It's part of the ERAS protocol. I'm not going to make you remember the ERAS. But basically what it is just a drug that really helps keep the bowels kind of in their neurogenic kind of things like intact so they don't get stuck. Okay? And then just minimizing bowel manipulation. If we don't have to touch it, we won't. GI bleeding. So these are more so for our critically ill patients. Okay? If you're just going in for a Foley, an Appy, you're in and out, there's not a lot of things going on in the belly, we're not going to put you on a PPI. But if you are a critically ill patient, they're going to be intubated for a while, they are maybe not having tube feeds or they're on tube feeds for a long time, we're going to actually put them on a PPI while they're intubated, okay, or at least while they're in their critical state. Stress from a critical illness can actually cause GI ulcers. So PPIs and a H2 blocker, if we give that to them preemptively or prophylactically, it can sometimes lower the risk of these ulcers happening. Anastomotic leaks. So I kind of told you how we put stuff back together is called anastomosis. Okay, putting two ends back together. Say we cut two ends because there was an injury in some of the bowel. Putting them back together, that's called anastomotic or anastomosis. Okay, a lot of times we do that now with staples. Those can break down. Okay, if you have pancreatic juices because there's a little nick to your pancreas or your pancreas is pissed off, and now you have pancreatic juices on your or around your anastomotic spot, what does pancreatic juices do? It breaks stuff down. It's what our body uses in our intestines to break food down, right? So if it touches other things, it's still going to do what it's made to do and break stuff down, okay? Which is why we leave behind drains and that kind of thing. Jaundice. Most of the time this is going to be caused by medications that we give them. Not very often do we throw them into liver failure, but if they're in renal failure, they can then go into liver failure from that hepatorenal syndrome. So just knowing that they have renal issues is going to be really important. Keeping up their nutrition. And calculus, calculus, really. Cholecystitis, this is without a stone. Okay, cholecystitis, normally you have stones in which causes the cholecystitis. This is from that acute or severe critical injury or illness. Okay, your body is just under so much stress from whatever it's trying to heal that you're basically, just like your liver, right? Your gallbladder then says, well, I'm pissed off too. I'm going to flare up and be a nuisance. Okay, it's not caused by anything other than the critical illness that they're currently in. And pancreatitis, if we're doing biliary type surgeries or if we're doing VRCPs, which you should have learned about in GI, we can cause pancreatitis. If we do intraoperative cholangiograms, we can sometimes cause pancreatitis. Certain medications we give them can cause pancreatitis. A lot of things. Alright. The lovely C. diff. Pseudomembranous colitis, antibiotic-associated diarrhea. The most common offenders, clindamycin, cephalosporins, and fluoroquinolones. Basically, it's just a disruption of your gut flora, and this is an opportunistic bug that will then flourish and cause very loose stools, or you have to have at least more than 3 in 24 hours. Okay, the stool will be like hot neon green and have a very distinct smell. Like once you've smelled C. diff, like you're gonna be like, oh yeah, no, that's right. If you've seen it, smelled it, it's just one of those things that once you do, you're like, sure. We try to send stool samples. Now, if they are having just normal diarrhea because they're on liquid feeds and antibiotics, okay, if you're putting in liquid, most likely you're going to get out liquid. But if you preemptively say, oh no, I think this is C. diff, and it's not, that patient is going to go under contact precautions. Meaning, to go into that room, you have to be in a gown, gloves, mask. Okay? So if you don't have to do that, if you think that, well, it doesn't look like C. diff, the patient's not doing too bad, like they don't look too sick, then don't necessarily, cause, sound the alarm if you don't need to. Okay? How do we treat it? Oral vanc, not IV vanc. IV vanc does not cross over into the GI tract. It has to be oral. We sometimes add metronidazole just because the gut loves metronidazole. We can also do fecal transplants, which are fun, sure. I get to see one. I'm still sticking with my POV, my unicorn though. basically they take stool, they radiate it, they kind of test it to make sure it's got all the normal gut bugs that you're supposed to have, and then transplant it into that patient's vesicle to replant, like to replenish all of their normal gut flora that we wiped away. Okay. Again, I've never seen it, but it is something that we can do. If it's bad enough, we can take their entire colon. Okay. That is a last resort. Nothing's working, and they're just getting sicker and sicker. We'll just take their colon. Okay. How do you prevent it? Hand washing. Purell and alcohol-based cleansers do not kill this bug. You have to wash your hands with soap and water. Judicious uses of antibiotics. So if you have a patient who doesn't need to be on an antibiotic anymore, this is why you review all of their meds every day to make sure that, like, oh shit, this patient's been on this antibiotic for 2 weeks. We didn't catch it, right? Oh, they only needed it for 3 days. Hopefully that's not the case, right? So we look at their med list every single morning when we round on them to see what can we come off. Right? Judicial medications. Contact precautions, like I talked about. Avoiding gastric acid suppression. So these people, we will not actually, if we can, try not to have them on a PPI or a true blocker. If we want their acid, we want their gut flora, and if we suppress it, that bacteria, the C. diff, is just going to flourish. Okay, renal complications, oliguria. We talked about this last week. Pre-renal dehydration, hypovolemia, most common. Consider this first. If they're not putting enough fluid out or urine out, just think we most likely did not resuscitate them enough while we were in the OR. Okay. Intrarenal, we wanted, maybe they got too much contrast. Maybe they got a nephrotoxic drug. Maybe we gave them too much diuretic and really put a strain on their kidneys. So doing this is why we do those baseline BUNs and CMPs. So that, you know, if we do have oliguria, we can do another CMP and compare it to their baseline to see if we give it to them. Anybody who's crush or electrical injury, automatically consider them at a renal risk. Okay. Myoglobin shows up as hemoglobin or red blood cells on a dipstick. So doing a urine microscopy or urine smear, looking at it under the microscope is how you find whether or not it's myoglobin or not. And it really gums up the glomerulus. Okay, it really gums up the kidneys. It is not, like, once you have that muscle breakdown and that release of myoglobin, the kidneys need fluid. This is sometimes where we don't actually have judicial fluid restrictions, right? We want to bombard their kidneys to flush them out as much as humanly possible. So we may actually say, hey, you need to drink a gallon a day, if not more. Okay, and if they're not able to take it orally, then we put them on an IV and put them in the hospital. We can use some of like our IV fluids to try to get it to flush out, but again, like the alkalis, I've never had to do that. Basically, it's really just a different type of solution. So post-renal, okay, what is causing their urine to not come out, right? They're producing urine, their kidneys are functioning great, but something's not allowing them to actually release that urine from their bladder. So is it prostate hypertrophy? Do we actually have a clot within their catheter, which is very common in trauma, right? They have a bladder injury. And a lot of blood in their bladder. It can absolutely clot, and we need to do like continuous irrigation within their bladder to keep those clots at bay. If they have a urethral injury, okay, their tube is no longer intact to get the urine from their bladder to the outside. Okay, if it's cut, it's not going to work. And then neurogenic bladder, we see this more so with the spinal cord injuries, the head injuries. Basically, their bladder just loses that natural ability to know when and receiving that signal to actually release that urine. We sometimes see it in diabetics as well. Antihistamines in old people. This is why we don't put Benadryl and we don't give Benadryl to people over the age of 65. Antihistamines cause urinary retention. So if you, as a primary care provider, are trying to treat somebody with, insomnia, don't give them Benadryl. You can use hydroxyzine, you can use a bunch of other stuff. Do not give them Benadryl unless you absolutely have to, but that is judicial. Antihistamines for a long period of time or in high doses can cause urinary retention. So how do we try to mitigate this, especially the post-op stuff? For the post-renal, we want to do have them pee before their surgery and pee after their surgery. This is why they can't pee, they can't leave the hospital until they pee. Okay? If it's been hours, bless you, and they haven't voided, we'll do a bladder scan to see actually how much is in there. If it's greater than like 300, we'll probably straight tap them and then they're staying the night. Okay? Unless it's really early in the day and they can just kind of sit and pack you and wait until their body really comes out of that anesthesia. Alright, we haven't learned about this yet, but abdominal perineal resection. Those are basically a very in-depth type of resection that we do for rectal cancers. Okay, so what that does though is that it can really disrupt the sacral plexus because of how much tissue and stuff that we're removing. And we normally leave a catheter in place for a while. Okay, 4 to 5 days, if not longer. Inguinal hernias with BPH, we try to treat that BPH prior to surgery. We don't want them straining, which may have caused the hernia in the first place. And then treatment is either that straight cap and observation, or just putting in a Foley for a few days, letting their body kind of heal. Especially, so this says 1,000. That's what I'll use as your book answer. But I mean, that's a liter, right? That's a lot of water in your bladder, or a lot of urine in your bladder. So depending on how they feel, if they feel like 500 or even 300 in a little old person is like extreme abdominal pain, I'm not going to use that 1,000. I'm going to use, okay, they are really obstructed, they can't pee, they're in pain, I have enough fluid in there. I mean, 250 milliliters is a Coke can of Coke, right? It's not a lot, but if it's distending their bladder enough that they're like, yeah, this hurts, I'm going to probably put a Foley in them and let them relax. All right, UTIs. Normally, so for most surgical cases, except the ones like that are really quick, are apneas and Foley, but if we're in there for a couple hours, we are going to put a Foley in. Okay, we want to make sure that bladder is decompressed and out of the way. But what that means is that UTIs are our most common complication. We want it inserted under sterile technique, and we want to remove it as soon as we possibly can. Okay. We also want to make sure that it's actually instilled correctly and not within the urethra. Okay, that's very painful. And we also want to make sure that for patients who are not circumcised, okay, that if we have to reduce their foreskin to put in the Foley, that we reduce that foreskin afterwards. Okay, we do not want to have phimosis or paraphimosis where we can't actually get it back to where we need to, which then leads to a circumcision. Okay, so don't do that to your male patients, that's mean. Also, if your patient has any sort of mental altered status, like they're just altered, I would either tape it down or make sure that it is in a region where they can't get to it, because I have had numerous old people pull it out because it's just bugging them. It's not something that they're used to. They're altered. They don't understand what they're doing, and so they pull it out with the balloon still intact. It can cause a lot of urethral injuries that way. All right, neurological conditions. A couple more minutes. Peripheral nerve nerve injuries, again, we kind of talked about this, positioning without stretch or putting pressure on the nerve. These are, so when we do a hernia repair, right, we're most likely going to, especially with an open hernia, like we're not doing it inside, we're cutting them actually from the outside. We will cut the ilioinguinal nerve, and it will cause skin numbness. They have to be counseled that that is something that is going to happen. Okay, there have been many studies that prove that after an open hernia repair, if we do not cut that, the pain in the region is extensive. It can be chronic and it can be very debilitating. So we just cut. Okay, mastectomy. We need to try to preserve that long thoracic nerve. We are not cutting this one. Okay, this is one that we do not want to cut because what will happen is that wing scapula. It loses, your body loses that ability to keep your shoulder girdles where it's supposed to. Thyroid and parathyroid, the recurrent laryngeal nerve, you have two. If we cut those when we're doing thyroid stuff, you're going to cause hoarseness and or paralysis of your vocal cords. And then carotid endarterectomies, we want to try to preserve that hypoglossal nerve because then you'll have a deviated tongue canal. Anytime you have mental status changes, you go see that patient, right? They wake up and the nurse is like, yeah, something's not right with them. You were the ones who saw them pre-op, you know their baseline. If you don't, if you came in and they were already in the OR, try to get someone, a nurse or a family member really, to be like, yeah, no, this is not their baseline. Or, yep, this is their baseline, this is just happy old Joe. Or not Joe, I shouldn't say Joe. We'll say Bob, right? Happy old Bob, just pleasantly, blissfully unaware of what's going on. So knowing what their baseline is really key because strokes and that kind of thing can happen intraoperatively, very commonly. So we want to know what's going on. How many slides do we have left? 15? Okay, we'll do those tomorrow. Go home. Good job sticking with it.